Good afternoon. I'll tell you a little bit more on the recent developments in maternal vaccination. So actually we're looking for, in the first slide, at a timeline of the last century, looking at outbreaks that occur around the globe, for example, influenza, measles, Zika and Ebola virus, and the response that people have made to this kind of infectious disease epidemics. So we try to find vaccines to prevent ourselves from disease, diphtheria vaccine, polio, meningococcal vaccines, and there's a lot more vaccines that we would like to have to combat these infectious diseases like RSV, GBS, CMV, malaria, etc. The lower part of this slide shows you the publications on the use of vaccines in pregnancy. Actually, it's only during the last decades that the number of publications is going up on this rising topic. It's rising and it's gaining more interest because we actually have a triple goal that we can have with this maternal vaccination. It's to protect the pregnant woman, her unborn child, and also the neonate later on, depending on the disease. The figure is part of the first chapter of a book that I was very lucky and happy and proud to edit with Dr. Christy Jones and Dr. Marta Nunes, and it's available through Elsevier and published this year. So although I've just told you that during the last decades the publications on maternal immunization are rising, it's actually not a new topic. Already more than 100 years ago, people were vaccinated with the vaccinia vaccine that conferred protection for mothers and infants against smallpox. In the 1930s and 40s, there were trials with the whole cell pertussis vaccine protecting infants from pertussis in the United States. Up to six vaccines were sometimes offered to pregnant women. They stopped this strategy because of the local side effects, so it was only in a study protocol that it was used, but it showed protective. And then later on in the 1960s, we have the influenza vaccine that has been recommended for pregnant women, and the tetanus vaccine, which is very well known to protect from maternal and neonatal tetanus. So there is quite some history of maternal immunization, and for the moment, in the year 2020, we have generally recommended the tetanus vaccine, still influenza inactivated vaccine, and in some areas with high burden of disease, we have the acellular pertussis vaccine that is administered in pregnancy. Sometimes other vaccines are recommended for disease prevention for the individual health of the woman or for specific endemic situations. For example, in areas with Japanese encephalitis or yellow fever, these vaccines are recommended in pregnancy too. In general, live vaccines or live attenuated vaccines are contraindicated in pregnancy because they provoke viremia in the pregnant woman, which can cause the virus to cross the placenta and infect the unborn child. Although no vaccine has ever proven to have embryotoxic or teratogenic effects. There's quite some data from PAHO on the accidental rubella vaccination of pregnant women during the measles elimination vaccine campaigns in the Americas, and there was never one single case of congenital rubella due to the vaccine. So we have to be prudent, but the data that are available are actually indicating that it's a theoretical risk and for the moment not a real risk. So whenever a woman is accidentally vaccinated with a live attenuated vaccine, the pregnancy should not be interrupted, but it should be surveyed. And I'd like to ask you as clinicians and healthcare professionals to report these cases of accidental vaccination in pregnancy. We can learn from it. So actually talking about maternal immunization, we outweigh the risk from the disease towards the risk from the vaccine, which is theoretical, and then in most of the cases, the beneficial effect of the vaccination when we have an available vaccine that is safe will outweigh the risk from the vaccine. The concept of maternal immunization for now is that we augment the number of maternal antibodies that we are inducing in the pregnant woman to be transported towards the unborn children to protect them either in utero or after delivery. And these are transported via the placenta or breast milk after delivery. The type of IgG that is induced by the vaccine is depending on the vaccine. For example, for pertussis, it's mostly IgG1, but for some other vaccines, it might be IgG2 that is induced, and that is to a lesser extent transported through the placenta. Of course, the antibody titer in the pregnant woman is of importance whenever she has high loads of antibodies. For example, when she had measles infection as a child, she will transport more antibodies, have more circulating antibodies in her body compared to a woman that was vaccinated as a child, and she will transport more antibodies. You can imagine that chronic maternal infections like malaria or HIV could have a negative effect on both the induction of antibodies and the transport of the antibodies. And we know that preterm infants receive less antibodies because the system of the FcRn receptor in the placenta transporting the maternal antibodies is not yet mature for the preterm born infants. It's mostly at the end of the 3rd trimester. So whenever we vaccinate late in pregnancy, there will be lesser antibodies available for transport, or whenever the child is born too early. So the antibodies offer protection, and that's what we count on in maternal immunization. But the flip side is that they can hamper the humoral infant immune responses to infant vaccination. And this is an example from a Belgian study we conducted, where after the primary series of vaccines in children where the mother was vaccinated with a Tdap-containing vaccine, the children responded to a lesser extent to their own pertussis vaccines compared to the control group. And this is called the interference or blunting of the humoral response in the children. Recent research has been conducted by the group of Galit Alter on the system serology. It's a way to look at your antibodies and to look at the specific features on a structural and a functional basis of the antibodies, how they work, how they are transported, and how well they work in the children. So they found out that the glycosylation profile of the antibodies, and this is the functional properties of the crystallizable fragment of IgG, that it is to do with the better or worse transport towards the children. And there's higher concentrations of specific antibodies promoting NK cell degranulation in the children with specific glycosylation profiles. So we can learn from these data that designing our maternal vaccines in a way that specific well-working and well-shaped antibodies are elicited that can be transported and are very functional in the infant might be beneficial. So we can learn for vaccine development and how specific antibodies are transported. Regarding the interference that I touched upon previously, there's recent data from a meta-analysis that was conducted by Dr. Abu Raya from the University of British Columbia, and he compiled data from several RCTs from around the globe, again on pertussis analysis, and he found that interference was found actually in every single trial post-primary series from the infant vaccination, and also after the booster immunization of the children in the 2nd year of life. So it's a general finding for pertussis. Whether this is clinically relevant is not, well, we think it's not really clinically relevant, because if it would be, we would see a shift in the surveillance data towards children of an older age that get susceptible more quickly and develop more pertussis compared to the younger ones, and that is actually not happening. Of course, older children are less prone to the very severe form of pertussis, but up to now, this interference does not seem to be clinically relevant. I'd like to focus for a minute on a randomized controlled trial that we did in Thailand. This is the first big trial prospectively conducted in almost 400 mother-infant pairs, and we vaccinated the mothers with a Tdap vaccine and administered to the children either an AP-containing vaccine or a WP-containing vaccine. There was a control group of EPI-WP children. This means children vaccinated as is recommended in the country according to the expanded program on immunization with the WP vaccine. So this is actually what is happening in Thailand in general. And AP and WP groups are children of vaccinated women with a Tdap vaccine receiving either AP or WP. And you can see after post-priming and also after the booster that the children in the EPI reached much higher antibody levels for anti-PT compared to the children in both the vaccinated cohorts. So there is also interference or blunting on the immune responses to the WP vaccine whenever an AP vaccine is administered in pregnancy. This is something to consider for regions and countries using the WP vaccine whenever they want to introduce the Tdap vaccination in pregnancy in their country. A bit more on blunting is a recent study that was published by a group from the RIVM in the Netherlands by Nienke Roberts and colleagues, and they confirm actually data that we have in Belgium and also in the UK on the heterologous blunting of both diphtheria and some of the pneumococcal antibodies in infants whenever the mother has received a Tdap vaccination in pregnancy. Especially for a serotype 19F, they find blunting of the infant immune response. Whether this is clinically relevant is also not really known, and what is more, the children remained within the seroprotective levels that are available in literature. So there was blunting, but they still reached seroprotective levels after vaccination. Talking about heterologous blunting, we also have data from Thailand that are impressed for the moment for diphtheria, tetanus, and HIP, Haemophilus influenzae type B antibodies, and actually there was a little bit of blunting for the diphtheria component and also for the HIP component in the children of the vaccinated women, but not for the tetanus. People have been looking also at the half-life of these maternal antibodies in view of this interference story. How long do these maternal antibodies remain and how long can they have an influence on the infant immune response? And a recent study by Mary Ely et al. Is showing a rather short half-life for pertussis antibodies, again of 29 to 36 weeks. A project sponsored by Imprint of the University of Oxford shows in a large analysis, a mathematical model done by Marin Voisey on 8 to 9 studies that were involved, that the half-lives indeed are around 30 days for duration for anti-PT antibodies. This is a study that is also conducted by Abu Raya from British Columbia, where he looked at the optimal timing of vaccination in pregnancy and the quality of the antibodies of the mother. So there's some discussion in publications whether or not to vaccinate early in pregnancy, late second trimester, or rather third trimester. It seems for the amount of antibodies that we want to elicit and transport that it might be better to vaccinate late second, beginning of third trimester. And this group looked at data of avidity, so quality of the antibodies, and also in this point of view, it seems that vaccinating a bit earlier in pregnancy at 28 to 30 weeks rather than 33 to 36 weeks shows better avidity of the antibodies. So this is another argument to vaccinate a bit earlier in pregnancy rather than later. This map is showing you the implementation of pertussis vaccination in pregnancy on a global level, and we try to fill it whenever new countries are recommending this strategy on a global level. Safety is a topic that is often referred to by both healthcare workers and the pregnant women themselves. Is it a safe strategy to vaccinate during pregnancy? And there's plenty of publications available on the safety of pertussis vaccination in pregnancy, also on the safety of influenza vaccination, both pandemic and seasonal vaccines. And 2 recent studies can be added to that one, both on Tdap, but there's confirming the safety on the major birth defects, and also when you do literature overview that the safety of this strategy is confirmed. When we look at the effectiveness, so whether the strategy is working, there's also plenty of data available for Tdap vaccination in pregnancy with an effectiveness of around 90%, whether your outcome variable is hospitalization for pertussis or lab-confirmed pertussis in different age categories in the early life. So it's a good vaccine effectiveness, and to that list can be added a recent publication by a group in Israel, where they measured after the introduction of Tdap in pregnancy on the decline in the incidence of pertussis and the decline in hospitalizations due to pertussis in the general population, reaching 60 and 50% respectively. And for the infants under the age of 2 months, they are the target population to protect, they found a decline in incidence of 71% and almost 60% in hospitalization. So this is showing, again, a very good effectiveness of the strategy on a national level. And then very short on a few future vaccines. So for CMV, there are vaccines in the pipeline, and last year, Professor Plotkin summarized them in an overview on vaccination against human cytomegalovirus. So these are actually the candidates in development. You know that severe complications occur also in 4 to 6% of congenitally infected children, that we need the antibodies to combat the first infection, but T cells seem to be important for reactivation. And we know to protect from congenital disease that the glycoprotein B and pentamer are better to be included in the vaccine. There is not yet a vaccine, but if we would have one, the target populations would be people receiving solid organs and seropositive stem cell recipients, but also women of childbearing age rather than the pregnant women themselves, so before the pregnancy. Both seropositive and seronegative women, and you could then argue to actually vaccinate pre-adolescents or adolescents and toddlers. Looking at malaria, there's been a nice overview of the malaria vaccine trials in pregnant women. It was based on a conference, and Dr. Duffy and colleagues have summarized that very nicely. So pregnancy malaria in first pregnancies is severe, with a lot of malaria-related disease complications and even death, because they have binding of the infected erythrocytes to very specific receptors and having higher parasitic load in the placenta. The hurdles for study conduct of malaria vaccines in pregnancy in low and middle income countries, and that's where it should be done because the burden of disease is the highest in these regions. But the hurdles are sometimes the accuracy of the gestational age measurement, the safety follow-up, the knowledge on the background rates of obstetrical complications, etc. Nevertheless, there's a malaria vaccine, the PFSPZ malaria vaccine, which is interrupting the parasite life cycle at the liver, which is in a phase 2 testing, and they are including women of childbearing age in Mali in the specific phase 2 trial, and going up to a trial into pregnant women very soon. I hope to see what the effect will be. Very short on RSV, you all know there's a roadmap of WHO in order to develop a vaccine against RSV, and there can be several strategies to vaccinate and protect the young infants and the young toddlers from RSV infection, including maternal vaccination, but also the combination of maternal vaccination and infant vaccination. And we also have the infant monoclonal antibody part that can be the approach or the strategy against RSV. There's a recent report by Dr. Mahdi and colleagues, and he will be talking at ESPID 2, so I presume he will also go into detail on this huge trial with an RSV F protein vaccine. It seems safe and little side effects. There were 2 animal models for toxicology studies, which I find very interesting, on cotton rats and rabbits. And we can learn from those toxicology studies in future for maternal immunization. But the vaccine efficacy measured in this trial in pregnancy showed a rather low efficacy of 39% against significant RSV lower respiratory tract infection. It was better in more severe disease endpoints. and it was better in low and middle income countries rather than in high income countries due to the higher severe disease incidence, earlier immunization, better alignment with the season, etc. And then last but not least, GBS. So group B Streptococcus, there's also a roadmap from WHO to develop a vaccine against GBS, and there's several vaccines also in the pipeline with, again, specific challenges to conduct these trials. And there is a report on first in human of a hexavalent GBS conjugate vaccine in healthy adults, which showed a good safety profile and a robust antibody response. So this is supporting actually the progress towards clinical trials in pregnant women. In summary, for this very quick and short overview on maternal immunization development, is that maternal immunization is safe and it is effective. New vaccines are being developed even specifically for pregnant women, and we learn from the ongoing studies on immunological parts of the maternal immunization on implementation, the effects in preterm-born infants, the efficacy studies. So the growing burden of the growing knowledge is helping us for future vaccine development and for ameliorating our strategy. It's important to know the burden of disease in both pregnant women and their unborn children. Safety has to be clear and has to be surveyed, and the vaccine efficacy is looked for in several trials. Thank you very much for your attention.